Hello, everyone, and welcome to today's webinar, The Paradigm of Lung Cancer, from Therapy Selection to Resistance Monitoring. I'm Susie Valdez of LabRoots, and I will be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Agilent. To learn more, visit them at agilent.com. Now, we encourage you to participate today by submitting any questions you might have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have any trouble seeing or hearing the presentation. I'd now like to welcome our speaker, Dr. Antonio Marchetti, a full professor of pathology and director of the Inter-Departmental Center of Advanced Molecular Diagnostics and Innovative Therapies at the University of Chieti-Pescara, Italy. Dr. Marchetti, you may now begin your presentation.
Hi. Good morning, good afternoon to everyone, everywhere. I know that you are many. As you can see from the title, my presentation will be focused on the molecular characterization of non-small cell lung cancer to select patients for targeted treatments, as well as to monitor patients during treatment by evaluating the presence of resistance-inducing mutations using state-of-the-art technologies, and in particular, next-generation sequencing. We'll speak quite a lot of next-generation sequencing today. Okay, lung cancer has been one of the first tumor types treated with targeted therapies. And nowadays, precision oncology has become the standard of care for oncogene-driven non-small cell lung cancer. Actually, the story started several years ago, in 2005, with the introduction of EGFR mutations as markers of sensitivity to first-generation tyrosine kinase inhibitors, such as gefitinib and erlotinib, and then second-generation and third-generation tyrosine kinase inhibitors, including afatinib and osimertinib, respectively. In the following years, several other biomarkers have been introduced in clinical practice. ALK1 in 2011, ROS1 5 years later in 2016, BRAF 1 year later, and then in 2019, 2020, we have an explosion of other biomarkers, including fusions in TRAC gene family, in TRAC 1, 2, 3, fusions and RET fusions, skipping of exon 14 of the MET gene, F2 mutations, mainly insertion duplications and gene copy number variations of HER2, and then KRAS mutations, and so on. You see here in red numbers the prevalence of these genetic alterations in non-small cell lung cancer in Europe and in Western countries. Since these mutations are mutually exclusive events, in the whole, more than 40% of patients have one or the other of these alterations. Actually, the prevalence in Asiatic countries is even higher, mainly due to the higher frequency of EGFR mutations in non-small cell lung cancer. In Western countries, the frequency is about 13%, whereas in Asiatic countries, it's more than 30%. So in Asiatic countries, the vast majority of non-small cell lung cancer are oncogene-driven cancers. As you see here, more than 20 different drugs are nowadays available for treatment of these patients. So we could summarize the situation stating that we are in the presence of a very complex diagnostic assessment and a very complex clinical management of non-small cell lung cancer patients. And the situation could be even more complex if we consider immunotherapy and the markers for immunotherapy, PD-L1, which is the widely used markers for specific patients, but other markers such as microsatellite instability, tumor mutational burden, are coming for the selection of patients for immunotherapy. So very complex scenario. Now, what is the role of the pathologist in the era of these new generation drugs? I think that the pathologist plays a key role in two different moments. First, a clinical diagnosis for the detection of sensitizing mutations, and this is done mainly on tissue samples. The pathologist uses plasma samples only when tissue is not available at diagnosis. A second key point is at progression for the detection of resistance-inducing mutations, and this is a very important key point. In this case, plasma for the analysis of circulating free DNA is usually more important than tissue, since it is more representative of the metastatic diffusion. So the rules are tissue is better than plasma at the clinical diagnosis, whereas plasma is better than tissue at progression. However, in some cases, a mutation present in tissue cannot be detected in plasma. This occurs mainly in patients with locally advanced disease. If you have a patient with a diffuse disease, it's much easier to detect the mutation in plasma. But if the mutation is localized, thoracic localized disease, in this case, it's much more difficult to detect the mutation. And you can detect it only in 20–25% of patients, even with the more sensitive technologies. So when a plasma test is negative, then tissue should be used to confirm the results. At clinical diagnosis, I think that we can state that it's almost all about tissue or cells. We should concentrate on tissue or cells. We get samples as resected tumors at surgery in about 25–30% of cases. Only 25–30% of patients are eligible for surgery. In the case of resected tumors, the amount of tissue is not a matter, but tissue should be well preserved. You can have a lot of tissue, but if you do not preserve it very well, you can do anything with this large amount of tissue. So we have to be careful with preservation of the tissue in the pathology department, fixation and conservation, storing. In the other cases, which represent about 75% of cases, we get tissue biopsies or cytology specimens. In these cases, in case of tissue biopsies or cytology specimens, the amount of biological material is usually very limited. This is sometimes really challenging. So for tissue biopsies or cell samples, an efficient management of the biologic material is mandatory, as you see in this scheme. When we have a limited amount of cells or tissue, first of all, we need to perform a morphological and immunophenotypical characterization of the tumor by using the minimum amount of tissue, just few slices, no more than 2–3 slices. So the rule is do the max with the min. Try to get the maximum with a minimum amount of tissue. Then we need to characterize the tumor for biomarkers that include predictive immunohistochemical biomarkers, such as PD-L1 for immunotherapy but also ALK1, ROS1 in terms of expression, and several genomic markers that need to be detected all together in a single test, possibly by next-generation sequencing. We need to test all the biomarkers together, since there are cases like the one you see in this slide that show concomitant alterations. In this case, for instance, the patient is ALK1 positive and PD-L1 positive. It's a rare case, but it can happen. And the oncologist needs to know the whole situation in order to accurately treat the patient. So it is extremely important to evaluate all of the markers, the tumor's markers together in a comprehensive report. This is the reason why next-generation sequencing, a multi-marker test, is becoming more and more important as a diagnostic tool. The molecular analysis at progression is mainly based on plasma samples, which are more representative, as I said, of the mutation status in patients with multiple metastases. Also in this case, NGS is the best method for the detection of the many different mutations involved in the acquisition of acquired resistance. Actually, we have dozens and dozens of different mutations involved in lung cancer acquired resistance. So once again, also for plasma, circulating tumor DNA, NGS is in pole position as a diagnostic test. Next generation sequencing, which is better defined as massive parallel sequencing. More than 2 years ago, I started to say that we should use the terms massive parallel sequencing instead of next generation sequencing. That doesn't mean anything. But next generation sequencing is so diffuse, the term, to indicate this technology, that we cannot remove it now. So I will say next generation sequencing. Next generation sequencing can allow to detect all the different types of genomic mutations we need to know for the treatment of patients in clinical practice and in clinical trials, including, as you see here, single nucleotide variants, insertion and deletions, copy number variations, translocations, fusions, together with many other applications in transgenomics, epigenomics, that represent the near future of NGS. So we are in the presence of a very versatile and powerful technology, NGS. There are two major sequencing strategies. One is based on PCR amplification for target enrichment, the so-called amplicon sequencing. Actually, I don't like this type of approach, especially for formalin-fixed paraffin-embedded samples, since by PCR amplification, we can introduce sequencing artifacts. We have worked quite a lot in the past with sequencing artifacts. You can lose a lot of time with sequencing artifacts. Nowadays, many strategies have been adopted to reduce PCR-induced artifacts, but if possible, it's better to avoid them. How can we do it? By a second approach. The second approach is based on hybridization in capture of targeted regions. This latter approach, in my opinion, can give us more accurate data, especially on paraffin-embedded samples. Anyhow, both approaches are used to prepare genomic libraries that then must be sequenced by NGS. Here are several commercially available NGS assays for the analysis of dozens of biomarkers we can define this NGSA reported in this table as small gene panels, since dozens of genes are investigated by these panels. And they are frequently used now in daily diagnostics in many labs everywhere in the world. They can be used on formalin-fixed paraffin-embedded tissue or plasma, as you see, requiring DNA or RNA for analysis. Large panels, including hundreds of genetic markers, are also available. You see here panels including from about 100 to more of 1,000 genes. Some of these panels can allow also the detection of additional alterations, including microsatellite instability and tumor mutation burden, which can be used for markers, as we say, for the selection of patients for immunotherapy. Large panels give us much more information and can be useful, particularly for the management of patients in clinical trials. So at this point, small panels are mainly used in daily practice, large panels for clinical trial, the assessment of mutations, alterations for clinical trials. At this point, question is important. Test in-house or send it out? In fact, samples can be tested by next-generation sequencing in-house or sent out to a reference laboratory. I think that there are a number of parameters reported here, listed here, that can influence the decision, including a highly cost investment for next-generation sequencing technology, the availability of technical and bioinformatics expertise, the specimen volume. A small sample is better managed in-house. The turnaround time requirements, the desire to access raw data. If you send out the sample, you don't usually get raw data. And other parameters can be taken into account. So it's up to you. It is a quite complex decision, of course, but it's up to you. At the University of Chieti, Italy, I lead the Department of Pathology of the Clinical Hospital, Ospedale Clinicizzato, Clinical Hospital, which represent referral centers for molecular diagnostics in our region. We perform our tests in-house and serve many other centers in our region. In our pathology department, we have recently implemented, among other technologies, the WhyAgilent next-generation sequencing system, which is a hardware, reagents, and software solution dedicated to labs that need to perform next-generation sequencing analysis in clinical practice, mainly in clinical practice. You see here a sort of timeline of the WhyAgilent NGS system implementation in our lab from May 2019 through January 2020 by adapting and optimizing different instrumentations and protocols. We decide to choose the WhyAgilent solution since it is based on the hybridization and capture technology. We have spoken about the two types of technologies and the fact that I personally like this kind of technology. And WhyAgilent is a leader from the beginning for this type of technology. In addition, WhyAgilent has recently introduced the SureSelect approach, which is based on the use of longer probes that tolerate larger mismatches. Moreover, it uses enzymatic fragmentation instead of other type of fragmentation of DNA, reducing the time of analysis and the amount of required DNA. I can say that 10 nanograms are usually more than sufficient for the test, and that's a good requirement. For all these reasons, we decide to go Agilent in next generation sequencing in our diagnostic lab. In particular, for lung cancer molecular diagnosis, we frequently use the SureSelect all-in-one lung cancer panel. This is a small panel, but extremely useful. Powerful panel, since it allows to detect single nucleotide variants and indels in 14 clinically important genes, the ones I show you now. Copy number variations in several genes, including MET and HER2 amplification, which are important alterations in lung cancer, and translocation in ALK1, ROS1, RET, and TRAC gene family, and TRAC1, and fibroblastic growth factor receptor 3. So, for all these reasons, I think that this small panel is a very interesting, very appealing panel. In addition to the standard all-in-one panel, if you want, you can get an all-in-one custom panel, which is available and allows to select biomarkers for from a panel of 110 genes, allowing the detection of 12 different fusions and 18 copy number variations. So you can choose the gene of your interest. Another interesting improvement from Agilent is the new NGS workflow for clinical applications, which includes the tape station for sample quantification and qualification. This is an extremely important step to evaluate the quality of DNA extracted from formalin-fixed paraffin and bed sections. The quality of the section and the quality of DNA extracted is a must to get a good next generation sequencing run. And the Magnis NGS station, a great improvement for preparation of genomic libraries that allow to automate all the process. You see here the tape station 4200, the station we use in our lab in the pre-analytic phase to test our samples for DNA concentration, to test samples for the level of degradation and assessment of fragmentation conditions. This is an essential step, as I say, to get reproducible and robust results from our samples. I think that the tape station is one of the most accurate systems available on the market for these purposes. And you see here how the samples are aligned and how constant are the results. And here you see the Magnis library preparation system, which has completely revolutionized our laboratory. The system comprises hardware, which is a mechatronic system, to move the samples to pipette, to share the samples, software and chemistry solutions to completely automate the process. It can prepare 8 libraries per run, up to 16 libraries per day, which is quite a lot. As I said, it is a sort of revolution for a lab. In fact, if you go manually, as you see here, the 9-hour workflow for library preparation requires 2.5 hours of hands-on time. Whereas, if you go automatically, by the Magnis system, the 9-hour workflow requires only 5 minutes of hands-on time. So, a great, important difference. When time is of essence, if you are in a hurry, it is possible to run libraries one after the other in a week for high throughput automation. You see here a library started on Monday, another on Tuesday, another on Wednesday. They can be produced one after the other, and you can get several libraries and several run in a week. After library preparation, the same tape station, can be used to evaluate the quality of the libraries. In this case, we used the all-in-one panel, small panel of formalin-free paraffin embedded tissue samples, and you can see the high quality and consistency of the samples processed. You see these samples. I think that it's very difficult, it's not impossible, to get results like this manually. So the Magnis system did a great work. And here the quality of samples prepared from circulating free DNA. So on plasma samples. Also in this case, note the consistency of the results we obtained. We have recently used the all-in-one system to accurately monitor patients treated with anti-EGFR tyrosine kinase inhibitors for the presence of resistance-inducing mutations in plasma. And we have implemented and published in this paper, as you see, a new algorithm for early prediction of resistance in non-small cell lung cancer patients. Very important to predict resistance very early so that the oncologist can decide how to manage the patient. So the all-in-one test was proven to be very useful also on liquid biopsy in our lab. But let's come now to some real-world cases tested by NGS in our laboratory. As a referral center, we usually test more than 20 non-small cell lung cancer samples per week. So I will show you some of the last cases we have investigated. Case 1. This is the case of a young patient who was diagnosed as EGFR and ALK1 negative in another center. This patient was found to be ALK1 positive by FISH in our center. Indeed, it was a quite difficult case with high polysemy complicating the finding. You see here high polysomic cells that rendered the test very difficult. The patient started a treatment with crizotinib, a first generation TKI against ALK1 that was maintained for 2 years. Then at progression, he was treated with alectinib, a second generation tyrosine kinase inhibitor, for more than 2 years, until he got to a rapid progression with liver metastasis. At this point, we performed the all-in-one test on a plasma sample on circulating free DNA that showed a resistance-inducing ALK1 mutation, specifically a TC substitution at nucleotide 3512, a well-known inducing resistance mutation, ALK1 inducing resistance mutation. On the basis of this finding, the treatment was switched to lorlatinib, a third generation TKI. So this patient did a first, second, and third generation TKI, according to the mutation he carried. After 1 week, patient started to recover, resulting in about 1 year more lifespan. This is just to say the importance of a test like this one during monitoring. The patient can be strictly monitored by NGS during treatment with different tyrosine kinase inhibitors. Case 2 is another case that can allow me to introduce you to another possibility for NGS. This case shows the importance of an NGS test not only to assess predictive markers, but also for tumor diagnosis. In this clinical case, 3 samples were obtained from a single patient. Sample 1, 2, and 3 that you see in the 2 slides. Sample 1 corresponded to a lung adenocarcinoma, a small, well-differentiated lung adenocarcinoma, whereas sample 2 and 3 were 2 metastatic lesions in thoracic lymph nodes. Sample 2 had an adenocarcinoma histology. Sample 3 had a squamous histology. Very difficult situation for a pathologist. The all-in-one test, NGS test, revealed a KRAS mutation in sample 1 and a P53 mutation in sample 2 and 3, the same P53 mutation. This data indicated that the 2 metastases were not related to the adenocarcinoma in sample 1. Indeed, another primary tumor, an adenosquamous carcinoma, was later found by clinicians in these patients, giving rise to the 2 different metastatic sites in sample 2 and 3. So the all-in-one test allowed to distinguish 2 different types of concomitant tumors, an adenocarcinoma and an adenosquamous carcinoma, based on different genomic alterations. And this is just one of several diagnostic problems solved by NGS in our center. So I clearly believe that NGS is important also for diagnostic purposes, not only as a predictive test. Case 3. This is the case of a patient from which a very small biopsy was obtained for molecular diagnosis. The amount of tissue was very, very limited. The tissue in this case was so scarce that we decided to test it directly by the all-in-one NGSA without any other previous analysis, only NGS at the beginning, due to the very low amount of tissue available. EGFR, ALK1, ROS1, and BRAF markers were found previously to be negative. Whereas this test, the NGS test, allowed to detect a clear RB2 amplification. Yes, because this test, the all-in-one test, can easily detect RB2 amplifications. Just a moment. The tumor was then subjected to immunohistochemical analysis. You see here the immunohistochemistry, a strong immunoreaction indicating the expression of RB2 in many cells, and followed by FISH analysis performed on the Dako Omnis instrument that confirmed a clear RB2 amplification. The patient was then treated with a new drug, Enhertu, a new drug which is a combination of trastuzumab plus deruxtecan. So the all-in-one test was found to be very effective in the detection of HER2 copy number variation in these patients. Case 4. This is another case of a young woman with a metastatic diffusion of an undifferentiated sarcoma with pulmonary manifestations. The tumor was previously found to be EGFR, ALK1, ROS1, PD-L1 negative in another center. We subject the case to the all-in-one test, and we found a TRAC1 fusion that allowed a treatment with a specific larotrectinib, Very specific, very efficient anti-entrap therapy. Finally, I would like to show you this case in which we found an EGFR resistance mutation acquired during treatment. This EGFR positive patient was a long survivor. Actually, she was the longest survivor in our series. She started with gefitinib in 2005, and she was treated for 11 years until progression occurred in 2016 due to a T790M mutation. At this point, the oncologist decided to treat her with osimertinib, a third generation TKI. At progression, after 4 years of osimertinib treatment, we decided to investigate the tumor with the all-in-one NGS test that showed a C787S mutation. As you know, this type of mutation can be located in cis or in trans with respect to the T790M mutation. Cis mutations are on the same allele. Trans mutations are located on different alleles. Cis mutations are the worst since they are resistant to combined therapies, first plus third generation TKI. Unfortunately, this patient had a cis mutation. However, the patient was treated in our clinical center with an innovative therapy in a specific trial. But for me now, it's important to show you how the all-in-one test could easily detect the T790M mutation and the C797S mutation, red and green respectively, located on the same allele, which is important, clinically important. Now, we have recently performed a test that showed that the power of NGS and the diagnostics. We select 35 non-small cell lung cancer patients who were found to be negative for the main biomarkers, EGFR, ALK, ROS, BRAF, previously investigated by conventional reverse transcription PCR test in our or other laboratories. The DNA of these patients was subjected to the all-in-one NGS test that revealed in 8 cases, more than 20% of the series of these patients, druggable mutations that were missed with a single biomarker test. Among them, 2 EGFR mutations, including 2 triptic deletions, not seen by a commonly used reverse transcription PCR test for EGFR. I will show you later something more about these 2 deletions. 2 potentially treatable KRAS G12C mutations. There is a drug now to treat G12C mutations, RAS. A RET fusion, an insertion duplication of LB2, and a new fusion of NTRK1. I think that this data clearly indicate that if we do not use NGS, we can miss several mutations that nowadays can be treated in clinical practice. And now, I'll show you the 2 deletions, EGFR deletions, we have detected in these patients. Here you see the 2 cryptic deletions that are not detectable with most of the conventional reverse transcription PCR tests commercially available. They are longer and located in exon 19, a little bit outside of the classic deletion area. This is the reason why they are missed by common tests. Patients responded very well to osimertinib treatment. So it's a pity not to detect this kind of mutations. So I would recommend the use of the all-in-one test or NGS similar to the all-in-one test for mutation analysis in order not to miss these cryptic deletions. Now we are investigating further this problem, and we're trying to write a paper on this. Now I'm coming to my conclusions. The characterization of non-small cell lung cancer patients in the last year has progressively become a complex diagnostic act. The tissue available for diagnosis is usually very limited. Sometimes we need to resort to liquid biopsies since the tissue is too limited. The number of molecular markers to be investigated has progressively increased in the recent years. NGS analysis is now a must for an accurate diagnostic characterization. Dedicated NGS panels can identify different types of genomic alterations required for molecular targeted treatments. The workflow automation is very important. It is the only way that can favor the diffusion of NGS in the labs, since NGS is a quite complicated test to be performed. And with this, I'm finished. Thank you very much for your attention. If there are comments or questions, I'm here. Thank you.
And thank you so much, Dr. Marchetti, for that informative presentation. We will now start the live Q&A portion of the webinar. If you have any questions you'd like to ask, please do so now. Just click on that Ask a Question box located on the far left of your screen, and we'll answer as many questions as we have time for. So let's take a look. We already have some great questions coming in from our audience members. Dr. Marchetti, what hurdles did you experience for an established pathology lab starting new on NGS?
A great question. I think that the main criticism for an established pathology lab that want to move to NGS technology is the economical investments. As I said before, you need a capital for investment if you want to start an NGS activity. Most of the genomic platforms already today available are costly, several hundreds of thousands of dollars, especially if you need a high throughput technology. The cost for reagents is another point that need to be considered, but it is not higher. It is not higher than the cost of reagents for a limited number of single markers. Actually, in terms of reagents, you will save money at the end. This is because you can assess several biomarkers simultaneously. So if a laboratory already has the facilities to perform NGS, or it has the possibility of an economical investment, NGS is the most convenient approach, the most convenient way to afford molecular diagnosis nowadays. Another critical point, I think, would be the hands-on time. Hands-on time, especially for library preparation. This, until in the past, was a very critical point. However, with the aid of the automatic platforms today available, such as the Magnis platforms, this problem is now overcome, I think.
Thank you so much, Dr. Marchetti. Our next question coming in is a two-part question. What was there before NGS, and was there a mechanism for early easy diagnosis, or was it impossible to altogether?
What do you mean for early easy diagnosis? We can go early, but not very much at the moment. Early diagnosis is a very important step in pathology today, and a number of technologies are are now available mainly for the detection of methylation that could help us in detecting cancer, different type of cancer earlier. But I think that in the next year, we will have something more concrete. At the moment, early diagnosis is still a matter of investigation, I think.
Thank you so much. Now, when should the patient go to the biopsy plasma of tissue, and at early stage growth or later phase of cancer? Further, what is your take on the accessibility of the technology in the developing nations like India?
Like India, I don't see.
Would you like me to repeat the question?
Yeah.
Sure. The audience member wants to know, when should the patient go for the biopsy plasma of tissue? Should it be at early stage, growth, or later phase of cancer? Let's start with that part of the question.
I think that the question is still around the use of plasma instead of tissue for the detection of the different alterations. And I think that plasma can be used, but at the moment, the use of plasma samples has to be restricted to the evaluation of the resistance. Early detection of mutations in plasma for early diagnosis of cancer is still a matter of investigation, as I said. There are interesting results developing, and there are interesting trials, large trials in Great Britain, but at the moment I think that it's too early to speak about early detection of mutations in plasma.
Thank you so much. And the second part of this person's question was, what is your take on the accessibility of the technology in the developing nations like India?
I don't.
And if you want, Dr. Marchetti, you can write this audience member separately, and we can move on to the next question if you're more comfortable. Yeah. I think the major part of this question is, what is your take on the accessibility of technology in developing nations? So nations like third world countries or ones that are in the development stage, what is your take on how they have access to technology?
In developing countries, actually, I think that in developing countries, NGS technologies need to be implemented, of course, but the most tricky problem in developing countries is just to treat the patient for in clinical practice for using drugs that can be used in clinical practice. So I think that in developing countries, the NGS technologies will be activated later, and possibly now other technologies could be used together with NGS with the implementation of NGS in some centers. Some large centers, referral centers, could start the activity in developing countries, but most of the surrounding centers should continue using standard technologies in order to detect common alterations that need to be tested to select the patients.
Thank you so much. And Dr. Marchetti, how do you manage detection of fusions not reported in the literature?
Can you repeat this question?
Of course. How do you manage detection of fusions not reported in the literature, in research?
Okay.
How do you manage those detections?
Okay, that's a very interesting question. At the moment, the best way to detect genomic fusion is to use the high-quality RNA to detect rearrangements involving exonic regions of the genome. This could allow to reduce the cost. You can avoid difficulties of sequencing large intronic regions. In addition, this approach can allow to distinguish in-frame transcribed gene fusions versus out-of-frame fusions, giving us more accurate data for the detection of real gene fusions. So, RNA-based NGS would be the preferred method for the detection of gene fusions in cancer. However, good quality RNA is not always obtainable from formalin fixed paraffin-embedded samples. This is the reason why alternative DNA-based NGS strategies have been developed. Among these strategies, I think that the strategy developed by Agilent and adopted in the all-in-one lung genomic panel is one of the most interesting approaches available at the moment. If a known fusion is detected with this type of test, you can be quite confident that the results are real. A problem can arise if you detect a novel type of fusion. In this case, I would suggest to confirm the results by using the same approach on messenger RNA, or eventually another orthogonal method to detect a fusion. So for this type of fusion not reported in the literature, the all-in-one test can be used as a screening technology that needs confirmation by an orthogonal method.
Thank you so much, Dr. Marchetti. And we have time for a few more questions. How well is the interpretation software of Agilent compared to other competitors? Did that cover enough VUS, ethnicity evidences, and curation databases?
I can tell you that the software is a good software. It's quite easy to use, and it has been improved month after month. And so I think that it will improve also in the next months. So it's an affordable software and easy to use. That's the most important thing, and quite clear, especially for the detection of gene copy number variation. I think this software has been very important, and also for the detection of mutations in plasma. So I think that it's a great software, no problem at all on my side.
Thank you so much. And we have time for one more question. Dr. Marchetti, what is your vision in the future for IHC over NGS technology for cancer detection?
I think that immunohistochemistry will remain an important tool for cancer and cancer detection. In addition, I believe that next generation sequencing exists, but it exists also next generation immunohistochemistry. I mean, multiplex immunohistochemistry. I think that multiplex immunohistochemistry will become a very important tool for the pathologist in the near future. The possibility to detect several diagnostic or predictive biomarkers in a single section could be extremely important in cases for which the amount of available tissue is very limited, particularly in specific type of neoplastic diseases, including lung cancer, for which only small biopsy cytology material are available. However, I have shown in my presentation also the NGS technology will be increasingly used by pathologists in diagnostics. I mean for diagnostic purposes, not only to investigate different predictive biomarkers as we do now, but to help the pathologist in the fine characterization of tumor types. I think that the pathological classification of tumors will further change in the future, requiring more genomic data to better understand the main quality categories that characterize cancer cells growth and diffusion. So I think that NGS will become an additional diagnostic tool for future pathologists that will require genomic as well as protein expression data, high throughput immunohistochemistry, high throughput genomic analysis. That's the point.
Dr. Marchetti, thank you so much for your presentation today. Would you like to provide our audience members with any closing remarks?
Just to finish, I think that I thank very much WhyAgilent for the occasion allowing me to present our data and our diagnostic experience. We spend most of our time in the lab making diagnosis in diagnostics. Most of our life has been spent in diagnostics. So thank you for your time, and I hope that our experience could be useful for you if you want to start with NGS in the near future. Thank you to all.
And thank you again, sir, for your time today and for your important research. And I also want to thank LabRoots and our sponsor, Agilent, for underwriting today's educational webcast. Before we go, I want to also thank our audience for joining us today and for their interesting questions. Questions we did not have time for today, and those submitted during on-demand period, will be addressed by our speaker via the contact information you provided at the time of registration. And this webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone, and bye-bye.